So, hi, I'm Jerry Cohn. We're going to talk today about the things that we worry about as doctors and nurses as a team when patients have had interventions and they come back to the floor. So again, we've talked about things we worry about are hematomas, the evaluation of pulses, and we'll kind of talk all about that. I hope I'll shed some light on the mystery of pulses to y'all. And some other things that we obviously would be concerned about. So an intervention is a percutaneous procedure that is through the skin without a large incision to improve blood flow to an extremity that either has a wound, is threatened, or the patient has a symptom related to walking, like claudication. And y'all all know what claudication is, right? Yeah, that's basically muscular pain with walking because a large conduit artery is occluded, usually from atherosclerosis. So we do interventions a couple of ways. For example, if someone has a sore on their left foot, most of the time, where is the angio access site when you see them in recovery? Which side? Yeah, right. It turns out that we do most of our interventions by going in a retrograde, is what we would call it, fashion up to the aorta. We'll take pictures to make sure there's no inflow artery occlusive disease like a blockage in the iliac arteries or the aorta. And we see after that if we go up and over, we call it the bifurcation, where the iliac arteries divide from the aorta. If we go over that bifurcation with a long, we call it a sheath, but it's really like a large straw, that gives us the stability or pushability, we say in the lingo, to be able to negotiate catheters and wires through a blockage. And then when we do that, then if we get a wire across a blockage and achieve what we call re-entry, which means it gets into the artery downstream that's open, then we have a train track that we can either, we've got a thing called an atherectomy where we can debulk the blockage and open a new channel, or we can keep it open with a lattice like a stent or a balloon. And what we pick kind of depends on how long it is and where it is. What are some of the complications that we see that you would notify us about with the procedure that I've just described? Certainly one of them would be bleeding, right. Normally speaking, you can't do this intervention without some blood thinner, and blood thinner most of the time is heparin. And generally speaking, we will look with an ultrasound when we stick, because we want to make sure we're sticking the artery where we or you can compress it easily. And that turns out that that's over the femoral head. If you look on x-ray and you see the femoral head there, that's right where the common femoral artery is most of the time. We want to stick the common femoral artery usually, because we don't want to stick around the deep femoral artery, the profundifemoral artery, or the superficial femoral artery, because it's a smaller artery and it can become occluded if we put large things in it, or if we use those sealing devices, which are, when they work, better for me and for y'all, because the patient doesn't have to lay for 5 hours, doesn't get a big sandbag on them, doesn't get mad at you because they can't move around. Those sealing devices can be placed safely in the common femoral artery, not in the superficial femoral artery usually because it'll occlude them, not in somebody that's got a lot of calcium in their artery because the little foot pedal on these are Angio devices, y'all have all seen patients like that. But if that Angio device, we put it in, and when we deploy it, it's got this polyglycolic, I believe it is, foot pad that opens up, and then when we pull it back, it's like a mandrel on the inside of the artery that we then push a piece of, it's an inert substance that sort of dissolves over time, and it just pushes a plug on top of the artery which seals it. There are other devices that work a little differently, but the point is, if you got a real calcified artery, that little foot pedal can get stuck on calcium, and then when you push it, you can occlude the artery. It may not be apparent immediately, but so when you evaluate a patient after an intervention, of course bleeding is important, but if they're complaining of right groin pain or right leg numbness that they didn't have before the intervention, and you do an investigation and see their pulses are different from what was determined by you earlier or given to you in a report, then something's happened. And the most likely thing is the Angio device has intruded on the artery. And that needs to be taken care of right away. So bleeding, of course, is important. Now, we talked about ultrasound. I think, and I'm not going to beat up my colleagues who also poke arteries, but I think all vascular surgeons and interventional radiologists, at least in my group, stick 100% of the time with ultrasound. Because, I mean, we've got the technology. Why wouldn't we want to see the artery go right where we want it, on the top wall, not in the deep femoral artery, you know, et cetera. When you stick blind, you know, if somebody has a deep femoral artery that happens to be higher than normal, you can certainly stick it and not know that until you've got a large hole in it. But you have to be careful about bleeding in the following circumstances. If you see a patient that is having a lot of back pain or feels like they have to go to the bathroom, that looks diaphoretic, that may have low blood pressure, what are you thinking? Where? They've had an intervention. Where's the most likely?
Well, the insertion site, most likely.
Right. Where's the blood? It's in the retroperitoneum. It was a high stick. And what happens is, if somebody bleeds, well, if it's on the bed, it's, you know, it's pretty straightforward. If they've got a big Cohn, then they've got a superficial groin hematoma. But if they're looking sicker than, and your little voice always tells you, doesn't it? You're like, there's something wrong with this person. And you're not, I'm not sure what it is, but there's something wrong with them. But if they are diaphoretic, if their blood pressure is sagging, if they've got tenderness, then the blood is actually dissected up underneath the inguinal ligament and is collecting in the retroperitoneum. And it can be life-threatening. The treatment there is support, high pressure as much as they'll let you tolerate it, and calling us right away. They'll need a CT scan, they may need an operation, or they may need a covered stent if they can't tolerate an operation. But retroperitoneal hematoma is our most feared complication after a otherwise uneventful percutaneous procedure. What other complications of a percutaneous procedure? I like to think that, generally speaking, I can either make something bleed or make something clot whenever I work with an artery, right? So, I'm sorry? PE would be unusual, related directly to the procedure. It can occur, but it's usually in somebody that's been sitting around the hospital, and it's a spontaneous clot in a deep vein that's mobilized. And she's got atheroma on atheroma, and we diligently do an intervention in her iliacs, for example, and she complains. She's got palpable pulses, but she complains of a Bluto that's very painful after the procedure. What happened?
It occluded?
No, she's got a palpable pulse.
Just partially included.
She embolized. She has a lot of debris in her iliac vessels, and when we opened the stent, some of that debris, which is friable, got loose and went downstream. We see it sometimes after, I did an endograft on a gentleman a couple weeks ago, and it wasn't apparent until the next day when he went home that he had Bluto's. We call it Bluto Syndrome because it can happen before we do anything. If somebody has a lot of atheroma in their iliac arteries and that debris goes downstream, it lodges in an end artery in the toe, and that becomes real cyanotic or blue. In some cases, they lose their toes. What's the treatment for that? Heparin doesn't usually work because it's cholesterol that's stuck in the artery. The best you can do is try to improve the blood flow by making sure their pain's controlled, their blood pressure as good as it can be, statin, dual antiplatelet therapy. Sometimes we use vasodilators like the cilostazol, which you might see people on for claudication. It's an off-label use, but sometimes we use that for the toes. And in rare instances, it's not pursuant to immediate postoperative care from your standpoint. But sometimes even those sympathectomies where the pain doctors will sort of hit the nerves, the lumbar nerves, to try to maximally vasodilate the toes, that can help the patients feel better. How do you guys evaluate pulses? Just a question. let's say I come to you and I've had an intervention. What do you do? Describe, when you give a report to your colleague, what you look for and how you describe them.
Palpable or Doppler?
Okay.
You can't palpate it and get a Doppler.
Do you guys get into the sophistication of the Doppler, the sound of the Doppler signal? In other words, triphasic, biphasic, monophasic? Are you interested in that at all, or no?
Yes.
Okay. Yeah, we've got a Doppler here. Can you pass it down? And it represents to us a normal blood vessel. That is a normal compliant blood vessel, one that distends, and one that has no proximal obstruction. If you think about the cycle of the heart, when the heart contracts, you have a rapid upstroke of blood, and that's the pulse we feel. Okay, an artery is a spring, okay, because there's a lot of elastin in it, and when the heart contracts, the artery dilates as you have systole. Then it's a loaded spring, right? What does a loaded spring do? It contracts. So a normal pulse or a normal waveform in an artery will have a rapid deceleration, and you'll actually have a little instantaneous negative flow. And that negative flow is that as the heart relaxes and all that blood goes back until the aortic valve closes, you have some sort of ebb and flow of blood in the artery. And then with diastole, you have a little slower forward propagation of blood. So the way it sounds, assuming I'm normal, and I checked the other day, at least my artery is normal. Now, what do you think the chances are this sucker works?
99.9%.
I want you to listen very carefully. Here at the end, you hear. Hear it? Thank God I'm triphasic. So that's triphasic. If you were to listen to my feet, or anybody's feet in here, I think, you'd have a triphasic waveform. Now, biphasic is the absence of that little. Biphasic to us usually means there's one level of blockage. So they're not usually in critical level of poor blood flow. In other words, if somebody asks me, a podiatrist, like, yeah, I gotta take this toe off, are they gonna have a wound problem? And I listen and they have biphasic signals, I'm gonna say, probably not. They may have a little blockage here and there, but you probably have enough blood flow that it'll heal. Or they say this person has rest pain. Do y'all know what rest pain is? Rest pain is like when you go in to see your patient and they're dangling their foot over the bed, or they've got it up close to them, while they're laying in bed. Those are people with 2 levels of blockage, and their leg is critically malnourished of blood. It's rest pain is what we call critical limb ischemia. Their leg is threatened. Somebody who has biphasic signals does not have a threatened leg. They're a claudicant. They have 1 level of blockage, but they have acceptable blood flow to keep the leg attached. So biphasic would go. There's some loss of compliance because the arteries have gotten a little stiffer and less likely to be like a spring because of the cholesterol in them. And there may be a level of blockage with collateral blood flows. Like if we have a person whose SFA is occluded, their superficial femoral artery, God has designed that artery to redirect blood flow from the deep femoral artery down across. And many people over time develop collateral blood flow such that you think with a completely blocked artery in your thigh that you'd have to have something done. I have hundreds of people in my clinic you never see that are completely fine because they've stopped smoking, they've exercised regularly, they don't have any problem. And in fact, the first line therapy for someone who comes to us with claudication is medical management, right? It's like antiplatelet therapy, a statin, exercise. Biphasic may be what we get. If we have somebody with rest pain and they have monophasic signals, and I know y'all have heard these, monophasic signals are like listening to the ocean and a seashell. That's CLI, that's critical limb ischemia. That's usually 2 levels of arterial insufficiency. and they usually need something done. They're going to have tissue loss, they're going to have a black toe, they're going to have a non-healing bland ulcer on the lateral aspect of their foot or on a toe. It looks kind of punched out, there's no granulation tissue. That's an arterial ulcer from lack of insufficiency, and that's 2 levels of blockage. They're either got fem-tib disease, fem-pop disease, ilio-fem disease. Somewhere there's 2 levels such that those collaterals that they normally can develop are insufficient to nourish the blood flow around the blockages that they have. But if I took someone who's, let's say, a frail older man, and they had rest pain, they didn't have tissue loss, and I took them to the operating room and I only did a femoral endarterectomy. That is, I ignored the superficial femoral artery because it would be a bigger operation for a frail person. I only cleaned out the groin. My strategy as a surgeon was to get blood flow to the deep femoral artery so that those collaterals could improve 1 level of circulation. I would expect, maybe not the first day, but I expect the second day, a change in their signals from monophasic to biphasic. And what I'm gambling on, and that's what they tell us in the doctor books, is if you do 1 level of circulation in the absence of tissue loss, you get a patient out of limb threat. They're going to be too frail to, run the, rock and roll marathon, even if Rascal Flatts is there. But they're not going to lose their leg. You can't do that if they have tissue loss. If they have tissue loss, we have to generate pulsatile blood flow to the extremity to heal those wounds. And that, what would we expect? We'd expect a palpable pulse or triphasic wave signals usually. So where are the pulses on the foot? Pedal, right. Right, we have, generally speaking, we have 3 vessels below our knee that y'all can interrogate and we can interrogate. Now we're an advantage, right, because we've seen the arteriogram. We might beat you up about what you feel, but it's only because we've seen them. You haven't. It's a mystery to you. But yes, the 3 vessels below the knee are the anterior tibial artery, right? It below the knee, if we had an angiogram, it comes out on the outside of the foot, and then it comes down on the top of the foot, right? That's what we call the pedal pulse. That's usually the easiest to feel. The posterior tibial artery runs medially, and it goes behind the medial malleolus. That's a little more difficult to feel. The tricks I do to kind of find when there aren't signals is I'll put the Doppler on, so I'll palpate behind the malleolus. So we feel behind the knee, behind the medial malleolus, and we look and we feel, and we don't use our thumb. And we make sure we're not hypertensive because we're mad at the residents. And generally we'll feel the pulse and not our own. If we can't feel those, then I'll listen. And I'll listen in the pedal, and I'll listen in the PT. You can hear venous signals in the absence of arterial signals, right? With the Doppler, have you all ever noticed that? How do you discriminate? Push down, exactly right. If you push down and that sucker goes away, you're listening to a vein. What's another way to determine where the pulse ought to be? Who's brave enough to take their shoe off? You a little nervous? I want y'all to listen. So she got great pedal signal. Hear that? Hear that? What I'm doing? What I'm doing is I'm pushing, does anybody have a napkin? Thank you very much. What I'm doing is I'm pushing on the plantar venous plexus. And when I push on it, I get venous return. And you listen with the Doppler and you go, just keep squeezing on the foot, as long as they let you. And you'll hear whoosh, 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 whoosh. When you hear that, the artery and the vein have got to be close to each other, right? Because they always run that way. Then you just listen. If you don't hear anything, you can convincingly tell me that there are no signals. Okay, I'm going to ask you questions like, can the patient move their foot? Can the patient feel their foot? Now, diabetics will be numb, but we grade ischemia. It's a Rutherford scale, and it's based on the preservation of motor and sensation. And if you have somebody, for example, that occluded their artery from an angioceal, you're going to find no pulses. It's an acute interruption, and you may have sensory or motor changes because the nerves are also malnourished of blood flow. So that's a percutaneous intervention. Generally speaking, if things are done right, the IR team will call you with report, and they will tell you what I got, or what Dr. Haresh got, or what whoever got. What was the snapshot in time when we patted ourselves on the back, put a little crown on our head, and said we're like the best interventionalists ever because we got a pulse, or we got a biphasic signal in a rock. You know what I mean? So they'll tell you what it is. So then you know what, if they'll say signals or pulses or whatever, you'll know what to look for. If that's lost, you call us and you say, Angio said that they had biphasic signals. I don't have a signal, and they have sensory changes. Something's happened, right? That's good, pertinent information that I know needs immediate attention. You might be wrong, and I won't beat you up. But if you've told me that language, I mean, it's like 911. You just gotta understand that that's what it is. Now, when I round and we do surgery on someone, or we do a comprehensive percutaneous revascularization, this is what I learned as a resident and as a vascular fellow. When you're late and you can't get all the information you want to get, put a hand on the foot. What have y'all noticed, or have you noticed, about somebody that's had a bypass the next day in terms of what their foot looks like and its temperature?
Warmer.
Hot, almost hotter than it should be, right? And you know why that is? Because people with chronic critical limb ischemia have adapted to maximal digital vasodilation. That's why, do you know what dependent rubor is? Dependent rubor is when you walk in the room to see somebody and you look at their feet and their foot is cherry red before you've done anything. And then you lay them back and you raise their foot up off against gravity, and it turns cadaveric. What's happened is there's such poor blood flow that the arterioles, the smaller arteries in the foot, are maximally dilated. They're like, come on, give me what you can give me. I need something, right? So guess what? So I give them something. I do a long leg vein bypass, or I do a fancy balloon, this, that, and the other thing, or Dr. Haresh does. Those digital arterioles are stupid for about 2 to 5 weeks. They don't auto-regulate right away. So I want a toasty dog. I want a hot, hyperemic foot. That makes me smile inside because I know that that is a successful intervention. We also have reperfusion edema. Now, of course, they get swelling because of the long incision, but even beyond that, these people, we have to tell them when we let them go home, do not keep that leg in a dependent position, or you will be calling Dr. Cohn in 3 days thinking you have a blood clot, because the reperfusion edema is also a sequelae of long-standing arterial insufficiency that causes edema. So I want to see a swollen hot leg the day after an intervention. I want to listen. I want to hear triphasic signals. They should have a palpable pulse or a triphasic signal in 90% of cases if I've done a vein bypass below the knee, because we've eliminated at least 2 levels of obstruction. Do you know the difference between an antegrade and a retrograde access when we do percutaneous interventions? It's important to know about that in report, because if you get called to put pressure, if somebody oozes a little bit, you need to know which direction to put pressure on. So, for example, I had a gentleman this week, I don't think y'all took care of it, but he had 2 antegrade antegrade access sites. So when we access an artery, right, there's some degree of subcutaneous tissue, sometimes more, sometimes less. And when we get an ultrasound, we see the artery, and we go approximately at a 45-degree angle from where the punctum of the skin is. The hole in the artery is not directly under where the hole in the skin is. It's probably 45 degrees. If we're going up and over, that's a retrograde approach. Then you know that the artery hole is above where the hole in the skin is. If they said they did antegrade, what that means is we didn't go up and over. For whatever reason, we went straight down the leg. So we prepped up the top of their belly, and we went in towards the artery from above. That's important. Why? Okay, you see somebody that's bleeding from the hole that we've made to do the arteriogram, and you of course say, dun-dun-dun, I'm going to hold pressure while someone else calls the doctor. Well, you hold where you think it is, but it's above there. You might actually make the bleeding worse because the hole in the artery is above rather than below. So you just need to make sure, you know, I mean, that's like extra credit points, but they should tell you that's an antegrade. But if they don't, you know, you want to kind of figure that out or see what's in the report. Questions?
So if it was an antegrade, you would put the, like you have a sandbag on it, you would put it going down this way.
Below, right.
If it was a retrograde, you would put it more coming up this
Correct.
way.
Correct.
The incision zone.
Correct. And
And that would, how would you know whether it's a retrograde or an antegrade?
well, hopefully they would tell you, or it would be dictated in the report. Now, of course, you're not going to have time to look on Epic while you're holding pressure.
So when getting the report, we can just question them and ask them.
Yeah. Have you right? Have y'all seen any arm accesses?
One.
No.
I have
One.
a couple we have.
Yeah.
Yeah. Sometimes we'll do brachial approaches. Brachial approaches are important because we want to make sure they have pulses afterwards. Radial, we want to make sure they have capillary refill. But very importantly, we want to know about any numbness, and we want to evaluate the upper arm, because the most common and feared complication is an axillary sheath hematoma. An axillary sheath hematoma can cause irreversible upper extremity nerve damage. It's actually one of the most litigious things in vascular interventions is the missing of an axillary sheath hematoma. Because they may have pulses, but if they have a large hematoma in the axillary sheath in the upper arm, they can have permanent nerve damage if it's not decompressed. The bottom line is, as we get more and more sophisticated with computers, there's no substitute for calling me and asking me. I mean,
Yeah.
some of us have worked together for 12, 13 years, you know, I mean, it's all right. We all have the same goal, and that's the patient safety.
Yes.
Yeah.
Can you just real briefly go over compartment syndrome? I mean, they briefly covered it in nursing school, but it's been such a long time that we don't
sure.
see it often.
Well, compartment syndrome is usually, well, let's talk about it. So, let's say that I'm on call and, you know, somebody falls asleep in their deer stand in a funny position, and then they get arterial insufficiency, for example, and they come down and I get it opened. And I get it opened by doing a surgery and retrieving the clot, okay? And let's say I didn't do something called a fasciotomy, and we'll talk about that in a minute. But, so what happens is that in the calf muscle, there are very specific, 4 of them, compartments that we describe anatomically, and they're basically bound by, is there a dry erase board behind you or not? It might be easier to show you all that. What I'm talking about is there are compartments, and this is not exactly right, but close. There are 4 compartments in the calf. Okay, if you look right here, the anterior compartment is right there. That's the most sensitive compartment to compartment syndrome because it's the smallest. So the anterior compartment, this is the tibia, this is a fibula. The anterior tibial artery comes off the popliteal artery and goes through this, what we call interosseous membrane, and that's really more like this. And so this is the anterior compartment, okay? That anterior compartment will be very tender when you push on it. If you do a range of motion with the big toe, you can elicit more pain. And what happens is that the muscle in here has been devoid of blood flow and then revascularized. And so what happens? It swells. There's an inflammatory reaction to the ischemia reperfusion. But if it is bound by a rigid fascial tether that's not going to give, then the first symptom is going to be pain because there's not enough room for the muscle, and then numbness in the perineal nerve distribution, foot drop, etc. And that's what compartment syndrome is. We can measure it by poking a needle in and doing a manometer, actually measuring the resting pressure. You can even do it in the ICU with an A-line, what do you call the thing? But basically, pressures less than 15 are not worrisome for compartment syndrome. When I've seen compartment syndrome, it's 30, 40, 50, 60, and they must be decompressed by fasciotomies. So normally, you will not see compartment syndrome from us unless we thought they were more chronic and weren't prone to it. In other words, people who have chronic ischemia with acute interruption may not be as sensitive to compartment syndrome as a normal person that gets their leg trapped under a car and occluded, and then we revascularize it because everything downstream is normal. But generally speaking, when we have someone who's interrupted blood flow from a gunshot wound or whatever, and we revascularize it, we always do empiric fasciotomies, because I've never seen anybody taken to court for doing a fasciotomy, but I've heard of a lot of people who didn't. The way we do a fasciotomy is we decompress the 4 compartments. This is the anterior up here. This is the lateral. And these are the deep, superficial, and deep posterior. Have y'all taken care of fasciotomy incisions before? Fasciotomy is done if the fibular head is here. We take care to avoid the superficial perineal nerve, but we make a cut in the skin and we open it like a biscuit can, and the muscle, you've seen it, and they just pop out. And we make a medial incision. Usually if we've been working on an artery below the knee, we've already done it because we move the calf muscle, the gastrocnemius down, and we take the soleus, which is the deeper muscle, off the tibia, and that decompresses the 2 medial compartments. But this lateral incision, which is the most sensitive to compartment syndrome, it basically, you can decompress the lateral and the anterior with a single incision, kind of halfway between the tibia and the fibula. And then in terms of treating it, you decompress it and you do supportive care, make sure they don't get rhabdomyolysis, alkalinize their urine, so the crystals from all the myoglobin from the dead and dying muscle doesn't precipitate in the kidneys and exacerbate the renal failure. And then, hopefully, we can close them in a few days. More commonly, we close one and do a skin graft on the other. Answer your question?
Thank you.
Great. Any other questions? Don't be afraid to call us. If you get an answer from the resident that's not right, don't be afraid to call us. Thank you all very much.
Thank you.